Welcome to the deep dive. Today, we're tackling a really tough condition, one that affects millions but maybe doesn't get the spotlight it deserves. Venous leg ulcers, VLUs. And look, these aren't just, simple wounds. They're the most severe stage of chronic venous insufficiency, CVI. It's serious stuff. For you listening, maybe you follow vascular health, maybe this is new, but here's why it matters. Up to 2% of people might get these. That's a huge number globally. And the real kicker, they take forever to heal if they heal at all, and they have this awful habit of coming back again and again.
That's exactly it. The healing is delayed, recurrence is common, and the impact on quality of life is just immense. Think about pain, mobility issues, constant wound care. It's draining. And the economic cost is staggering. The sources we looked at pointed to the UK's NHS spending upwards of £2 billion a year just managing these ulcers. It's unsustainable.
So when the standard treatments aren't cutting it, where do clinicians turn?
Well, they start looking for other options. Pharmacological adjuncts, basically medicines that can help the healing process along. And that's where Pentoxifylline, or PTX, comes into the picture. It's been around for a while, used for circulation problems. There was some older data suggesting it might help with VLUs, but it wasn't, definitive.
Right. So this deep dive is all about a major updated systematic review looking squarely at PTX. Our mission today is pretty clear. Based on this new pile of evidence, does PTX actually help these ulcers heal completely? And, maybe even more critically for that £2 billion problem, does it stop them from returning?
Those are the core questions. We need to know if it works in the short term for healing, and crucially, if it has any long-term benefit regarding recurrence.
Let's get into it. We'll break down the data, the good, the bad, and definitely the gaps. Okay, first things first. Let's really ground ourselves in what a VLU actually is, clinically speaking.
Right. It's the end stage, the most severe sign of chronic venous insufficiency. Fundamentally, the veins in the legs just aren't doing their job properly. They're not getting blood back up to the heart effectively.
And that failure causes problems lower down.
Exactly. You get this chronic backup, high-pressure venous hypertension in the lower leg veins. Over time, that pressure damages the skin, the tissues, makes them fragile until eventually the skin just breaks down. An ulcer forms.
And there's a specific classification for this?
Yes, the CEP system. It's the global standard for classifying venous disorders. Stands for clinical, etiological, anatomical, pathophysiological. And active venous ulcers, the open wounds we're talking about, they get classified as C6. That's the top end of the clinical severity scale.
C6. So that signifies a really significant level of tissue damage.
Absolutely. We're talking full-thickness skin loss. It's an open, active wound driven by that underlying venous pressure. And at that C6 level, the local environment is terrible for healing. You got poor circulation, constant inflammation, maybe infection risk. The body's natural repair mechanisms are really struggling to cope.
Okay, so given how tough these C6 ulcers are, what's the standard playbook? What's the first thing doctors try?
The absolute cornerstone, the non-negotiable first step, is compression therapy. Bandages, stockings, whatever it takes to apply external pressure.
How does that help?
It's basic physics, really. The compression squeezes the leg, which helps support the weak veins and crucially lowers that damaging high pressure. It reduces swelling, improves blood flow in the tiny vessels, gets more oxygen and nutrients to the wound bed. It creates a chance for healing.
But you said it's just a chance. Compression alone isn't always enough.
Often, no. Especially not for long-term resolution, which is why clinical practice has really shifted over the last couple of decades. We now understand it's vital to treat the underlying cause, the faulty vein causing the high pressure, not just the symptom, which is the ulcer.
Ah, okay, so fixing the plumbing, essentially.
Pretty much.
Yeah.
Modern guidelines strongly recommend adding in what's called superficial venous intervention. Things like endovenous ablation using heat or chemicals to close off the main leaky surface vein that's feeding the pressure problem.
So compression plus fixing the vein, does that work better?
Oh, absolutely. The evidence is really strong now. If you do that intervention, especially relatively early, say, within 6 months of the ulcer appearing, patients heal faster, and critically, the ulcers are much less likely to come back.
That sounds like a game changer. Compression plus intervention equals the gold standard.
It is. That combination approach offers the best outcomes we currently have.
So, back to the original question then. If we know this works, why are we even investigating an adjunct drug like PTX? Why isn't everyone just getting compression and ablation?
And that is the $1 million, or rather $2 billion question. It highlights a massive gap between the evidence and real-world practice. The hard truth is, despite knowing that intervention works best, a huge number of VLU patients around the world simply don't get it.
Why not? Lack of access. Cost.
All the above. Sometimes it's lack of trained specialists, sometimes it's no access to a vascular center, sometimes it's incredibly long waiting lists, sometimes it's just the healthcare system lacking the resources. It's a global problem.
So lots of people are stuck with just compression, even though we know it's not the optimal long-term solution.
Precisely. And that reality creates this urgent need for other effective options. We need treatments like PTX, could potentially be easy to administer, relatively inexpensive, something that can be added to compression to boost healing, especially for those patients who can't get or are waiting for intervention. We need more tools in the toolbox.
Okay, that makes sense. So let's focus on the specific tool, Pentoxifylline PTX. What exactly is it, chemically speaking, and how is it supposed to work on these tough C6 ulcers?
Right, so PTX is a xanthine derivative. Chemically, it's in the same broad family as things like caffeine, believe it or not, but its effect on the body is quite different.
Okay, caffeine for leg ulcers. Doesn't sound quite right.
No, not quite. Its mechanism is really focused on two things that go wrong in VLUs: poor blood flow and runaway inflammation. Its main trick is affecting the red blood cells themselves. It makes them more flexible, more bendy, if you like.
More flexible red blood cells. How does that help an ulcer?
Think about the area around a VLU. Because of that high venous pressure, the blood flow in the tiniest blood vessels, the capillaries, is really sluggish. The blood might even be thicker, more inflammatory. By making the red blood cells more pliable, PTX helps them literally squeeze through those narrow, congested capillaries more easily. It improves microcirculation, getting more oxygen and nutrients right to the wound edge where it's needed most.
Okay, boosting blood flow, that makes sense. What about the inflammation part?
Yeah, that's the other key aspect. Chronic, ongoing inflammation is a major barrier to wound healing. PTX seems to have anti-inflammatory properties. It can help dial down that excessive inflammatory response.
So, better blood flow and less inflammation.
That's the hypothesis. If you can improve the local blood supply and calm down the inflammation, you're creating a much better environment for the body's own repair processes to actually work. You can see why it's an attractive idea for a chronic wound like a VLU.
It definitely sounds promising on paper, but you mentioned this isn't the first time PTX has been looked at for VLUs. Why the need for this big, new systematic review now?
Good question. It really builds on and aims to improve upon a quite influential review from back in 2012 by Joel and colleagues. That 2012 review was the one that first strongly suggested PTX plus compression was better than compression alone for healing, but it had some significant limitations.
What were the issues with the older review?
Two main things. First, its focus wasn't strictly on complete ulcer healing. It looked at various measures of improvement, but complete closure is really the goal that matters most to patients and health systems. Second, and this was the really big gap, the 2012 review had almost no reliable information on whether PTX affected recurrence rates. Did the ulcer stay healed? We just didn't know from that data.
And things have changed since 2012 anyway, right? Like the emphasis on vein intervention.
Exactly. Clinical practice has evolved, the importance of SVI is now recognized, and crucially, more studies on PTX have actually been published since then. So the mission for this new review, the one we're diving into, was clear. Update everything, pull together all the research up to August 2023, use rigorous methods, focus laser sharp on complete healing, and actively hunt for any data at all, on recurrence.
Trying to move from suggestive evidence to something more solid, more certain.
Precisely. Can we say with more confidence, based on everything we know now, does PTX work for healing, and does it help keep ulcers away?
Okay, let's talk about how they did it. You said rigorous methods. This wasn't just a quick look around.
No, definitely not. They followed the PRISMA guidelines, preferred reporting items for systematic reviews and meta-analyses.
PRISMA, that's the gold standard, right? Ensures transparency.
It is. It means they had a predefined, systematic plan for how they searched for studies, how they decided which ones to include or exclude, and how they extracted the data. It's all about minimizing bias and making the process repeatable.
So who got included in their analysis? What kind of studies were they looking for?
They focused on adult patients over 18 who had a confirmed active VLU, that C6 classification we talked about.
Just venous ulcers.
Yes. Critically, they excluded studies that looked at mixed ulcers, say venous and arterial or purely arterial ulcers.
Why is that exclusion so important?
Because the underlying cause is completely different. Arterial ulcers are caused by lack of blood getting to the leg due to blocked arteries. Venous ulcers are caused by blood not getting out efficiently due to vein problems. The treatments are different, and PTX's mechanism is really aimed at the venous side, the microcirculation issues there. Mixing the data would just muddy the waters.
Makes sense. Keep the focus clean. What about language and dates?
They limited it to English language studies on humans, published anywhere between January 1980 and August 2023. So a really wide time frame, but focused language.
Okay. So after applying all these rules, filtering everything out, what did they end up with? How much data are we talking about?
They screened hundreds of papers initially, over 500, I think. But after applying all the inclusion and exclusion criteria, they landed on a final set of 10 studies for the main analysis. 9 of those were randomized controlled trials, RCTs, which is really what you want for assessing treatment effectiveness, as they minimize bias through random allocation. And there was also 1 observational cohort study included.
10 studies? Is that a lot? How many patients does that represent?
It's a decent number for this specific question. Altogether, those 10 studies involved a total of 1,025 participants. Just over half of them, 515 patients, received PTX as part of their treatment.
And where did these studies happen? Was it all in one country or region?
No, it was quite geographically diverse, actually, which is good. Studies came from the UK, Italy, Ireland, the USA, Iran, Macedonia, Brazil, a real mix of healthcare systems and populations.
And the time frame? Old studies, new studies?
A mix there, too. The publication dates range from 1990 all the way up to 2021, so it covers quite a long period of clinical practice. That spread, geographically and temporally, helps make the findings potentially more generalizable.
Okay, crucial detail. The treatment itself. What was the PTX protocol? Were they all using the same dose, the same way? Consistency matters for pooling data.
That was actually a point of relative strength. The majority of the studies were quite consistent. 9 out of the 10 used what seems to be the standard dose, 1,200 milligrams of PTX per day.
How is that usually taken?
Typically divided into 3 doses. So 400 milligrams 3 times a day, breakfast, lunch, dinner.
And for how long?
The usual treatment duration reported in these studies was around 24 weeks, so about 6 months.
Okay, 1,200 milligrams daily, split doses. For 6 months, that was the common approach. But you said 9 out of 10. What about the outliers?
Right. There were a couple of interesting variations. One study was particularly useful because it didn't just compare 1,200 milligrams to placebo. It also included a higher dose group testing 2,400 milligrams per day. That comparison gave us some interesting clues about healing speed later on.
Double the standard dose. Interesting. Any other variations?
One other study reported using intravenous PTX, so given directly into a vein, rather than the oral pills used in all the others. But even with the IV route, they stuck to that same total daily dosage of 1,200 milligrams.
So mostly oral, mostly 1,200 milligrams for 6 months, but with those couple of variations that might add nuance.
Exactly. These differences, like dose or route of administration, are part of what contributes to that statistical heterogeneity we'll need to talk about, but they also provide potentially valuable extra information.
Okay, let's get to the core results then, quantitative stuff. Based on pooling these RCTs, what did they find about complete ulcer healing? Did PTX actually work?
Yes. The headline finding is pretty striking. When they pooled the data from the randomized trials, they found that complete ulcer healing was achieved in 62% of the patients receiving PTX.
62%. How many patients is that?
That was 315 people out of the 515 who were in the PTX groups across those studies. So nearly 2/3 saw their ulcers fully close within that 12 to 24-week treatment window alongside their compression therapy.
That sounds pretty good. But how does it compare to the people who didn't get PTX, the control groups?
That's the crucial comparison and where the statistics get really interesting. The meta-analysis showed that taking PTS was associated with the significantly higher likelihood of complete healing compared to the control groups receiving placebo or just compression alone.
Significantly higher. How significant? Can we put a number on that?
We can. They calculated the pooled odds ratio, the OR. It came out at 3.02.
An odds ratio of 3.02. Okay, unpack that for us. What does 3.02 actually mean in practical terms?
Right. An odds ratio can be a bit abstract. Basically, an OR of 3.02 means that the odds of achieving complete ulcer healing were just over 3 times higher for patients taking PTX compared to those who weren't.
3 times the odds of healing. That sounds substantial.
It really is. In medical research, particularly for chronic conditions, finding a treatment that triples the odds of a positive outcome is a big deal. And the statistics backing this up were strong. The 95% confidence interval was reasonably tight, 1.89 to 4.82, and the p-value is less than 0.0001.
P less than 0.0001. So extremely unlikely this result is just due to chance.
Vanishingly unlikely. It indicates a very high degree of statistical certainty that the observed difference is real.
What about that one observational study? Did it show something similar?
It did show a trend in the same direction, yeah. In that cohort study, 57% of the PTX group healed versus 33% of the control group. However, in that specific study, the difference wasn't statistically significant, likely due to its design or smaller size compared to the pooled RCTs. But the trends was consistent.
Okay, so the main takeaway from the RCTs is a strong, significant boost in the likelihood of healing. What about the speed of healing? Did PTX make ulcers close faster?
This is where that one study testing the higher dose becomes really interesting. Remember the one comparing 1,200 milligrams, 2,400 milligram in placebo?
Yeah, the double dose one?
In that specific trial, the group receiving the higher PTX dose, 2,400 milligrams per day, showed a significantly shorter average healing time. Their ulcers closed on average in just 71 days.
71 days. How did that compare to placebo?
The placebo group in that same study took an average of 100 days to heal. So the higher dose of PTX appeared to shave almost a month, about 29 days off the healing time. And that difference was statistically significant.
Wow. Cutting healing time by nearly 30%, that would make a huge difference to a patient living with an ulcer.
Absolutely. Less time in pain, less time with dressings, less time with restricted mobility. It's a clinically meaningful difference.
But wait, did the standard dose, the 1,200 milligram, also speed up healing in that study?
Interestingly, no. In that particular trial, the standard 1,200 milligram dose group did not show a statistically significant difference in the time to healing compared to placebo. Only the 2,400 milligram group did.
Huh. So maybe dose matters not just for if you heal, but how fast you heal.
It certainly raises that possibility. It's only one study, so we can't overstate it, but it does suggest there might be a dose-response relationship. Maybe 1,200 milligrams is enough to improve the overall rate of healing significantly, as shown in the pooled data, but perhaps you need that higher 2,400 milligram dose to really accelerate the process noticeably. It's definitely something needing more investigation.
Okay, this sounds very positive overall, but let's address the statistical complexity. You mentioned heterogeneity before. Pooling studies from different places, different times, there must have been variations. How messy was the data?
You're right, there was significant heterogeneity. They calculated the I statistic, which measures the percentage of variation across studies that's due to genuine differences rather than just chance. It came out at 61%.
High of 61%. Is that high? What does it mean?
Yes, conventionally, anything over 50% is considered substantial or high heterogeneity. An I of 61% means that a large chunk, over half, of the observed differences in healing rates between the studies is likely due to real differences in things like the patient populations, how severe their ulcers were initially, maybe how well compression was applied, or other methodological variations.
Does high heterogeneity weaken the overall conclusion, like that OR of 3.02?
It means we have to be cautious. It tells us the effect of PTX might not be exactly the same in every single situation or a patient group. However, the researchers anticipated this and used an appropriate statistical method to account for it.
How do they account for it?
They used a random effects model for the meta-analysis.
Random effects model. We hear that term a lot. Why is it important here?
Okay, so a simpler fixed effect model assumes there's one single true effect size, and all studies are just estimating that same effect. But when you have high heterogeneity, like 61%, that assumption doesn't really hold water. The studies are genuinely different. A random effects model, on the other hand, assumes the true effect can actually vary from study to study. Maybe PTX works slightly better in one population than another. It incorporates this between-study variability into the calculation.
And what's the result of using that model?
It generally gives a more conservative estimate. It gives more weight to smaller studies and produces a wider confidence interval around the pooled result. So that OR of 3.02, calculated using a random effects model, is actually a more cautious but ultimately more robust and generalizable estimate of the average benefit you might expect across different settings, despite the variability between the studies.
Got it. So the model acknowledges the differences and gives a more realistic average effect.
Exactly. It doesn't ignore the heterogeneity, it accounts for it.
Okay, so the evidence for healing seems pretty strong, albeit with that heterogeneity caveat. But you said at the start, the real long-term issue with VLUs is recurrence, the ulcers coming back. What did the review find about that?
Well, this is where we hit a major wall.
A wall? What do you mean?
I mean, zero data. The systematic review found that the rate and the time of ulcer recurrence were simply not recorded in any of the 10 studies included. Not a single one reported on long-term follow-up after healing.
Wait, none of them? At all?
None of them. It's quite startling, actually. All that effort to see if PTX helped ulcers heal, but apparently no effort in these specific studies to see if they stayed healed after the treatment stopped.
That seems like a massive oversight. Why is recurrence data so critical?
Because VLU is fundamentally a chronic recurring disease. We know from lots of other research that once you've had one VLU, your risk of getting another one is dramatically higher. Recurrence rates can be really high, sometimes 50% or more within a few years. So think about it. If PTX helps an ulcer heal in, say, 4 months instead of 6, that's great. But if that ulcer just comes back 3 months later, just as it would have without PTX, then what have we really gained long term? We've spent money and time on the drug for potentially only a very temporary benefit.
So without recurrence data, we can't judge the true value or the cost effectiveness.
Exactly. Evaluating recurrence is absolutely essential for understanding the real long-term impact of any VLU treatment. Does it just patch the problem temporarily, or does it contribute to a more durable solution? Right now, for PTX, based on this review's included studies, we simply don't have that answer.
Why would researchers just not track it? Is it that hard to do?
It is significantly harder, yes. Tracking recurrence means following patients for a long time after the initial treatment period ends and the ulcer has healed. You might need to follow them for 1 year, 2 years, maybe longer. That requires sustained funding, dedicated staff, and patients who are willing and able to keep coming back for follow-up visits long after they feel cured. Many of these PTX studies were older, perhaps smaller, maybe focused purely on achieving that primary endpoint of healing within 6 months. Long-term follow-up might have been beyond their scope or budget.
Logistically difficult, but still a huge gap in knowledge.
A critical gap. Until we have good recurrence data, preferably from large, well-conducted trials with long follow-up, the true place of PTX in managing the chronic VLU cycle remains uncertain.
Okay, let's switch gears slightly. What about safety? If people are taking this drug 3 times a day for 6 months, were there side effects, adverse events, or AEs?
Yes, they looked at AEs. Data on adverse events was reported in 5 of the 9 RCTs, covering about 521 participants in total between the PTX and control groups in those specific studies.
And what did they find? Was PTX rough on patients?
The findings were sort of mixed, but generally reassuring. Patients receiving PTX did report more adverse events overall compared to the control groups. The calculated odds ratio for experiencing any AE was 1.89.
So nearly twice the odds of having some kind of side effect if you took PTX.
Numerically, yes, but here's the crucial statistical point. That difference was not statistically significant. The p-value was 0.09.
P.09. So close, but technically doesn't meet the standard threshold for significance, which is usually 0.05.
Correct. It means we can't confidently conclude, based on this data, that PTX definitively causes more adverse events than placebo. There's a trend suggesting it might, but it didn't reach statistical certainty.
What kind of side effects were people reporting? Anything serious?
The vast majority of reported AEs were related to the gastrointestinal system. Things like feeling nauseous, indigestion, maybe some diarrhea. This isn't particularly surprising for an oral medication taken multiple times a day. Importantly, there weren't reports of widespread serious adverse events specifically linked to the drug in these trials. However, it is worth noting that 3 of the studies did report that some participants withdrew from the trial because of adverse events.
So while maybe not statistically significant overall, the side effects were bothersome enough for some people to stop taking the drug.
It seems so, for a small subset of patients at least. Tolerability is always an individual thing. But overall, the safety profile didn't raise major red flags in this review, especially considering the potential benefit for healing.
Okay, so moderate certainty on healing, no data on recurrence, and maybe slightly more minor GI side effects, but not statistically proven. Let's talk about the quality of the studies themselves. How good was the evidence base overall?
This is where we need to inject some caution again. The review used the GRADE approach, grading of recommendations, assessment, development, and evaluation, to formally assess the overall certainty of the evidence for the primary outcome, complete ulcer healing. Despite that strong odds ratio of 3.02, the certainty of the evidence was judged to be only moderate, not high.
Hold on, 3 times the odds of healing sounds pretty convincing. Why only moderate certainty? What dragged the quality down?
It comes down to 2 main factors we've already touched on: that substantial statistical heterogeneity, the FT of 61%, and, perhaps more importantly, concerns about the methodological quality, the risk of biases in the underlying studies themselves.
Risk of bias. What kind of problems did they find?
The reviewers used the Cochrane Risk of Bias tool, ROB2, to assess each RCT. They found that 6 of the 9 RCTs had some concerns regarding their methodological rigor. These concerns varied, but common issues included things like potential problems with the randomization process itself. Was it truly random? Lack of adequate blinding. Did patients or researchers know who was getting PTX versus placebo? And incomplete outcome data. Were patients lost to follow-up, and was that handled properly? Sometimes protocols weren't followed exactly as published.
So flaws in how the studies were designed or run could potentially skew the results.
Exactly. If there's bias in the individual studies, then pooling them together, even with sophisticated statistics, means the overall result might also be biased. The moderate grade rating reflects this uncertainty. We're reasonably confident in the effect, but acknowledge that better quality research could potentially shift the estimate.
And you mentioned many of these studies were older. Does that play a role?
Absolutely. That's a key context point. The majority of the included papers were conducted quite some time ago, some dating back to the early 90s. Back then, methodological standards and reporting requirements for clinical trials were often less stringent than they are today. For example, many older studies had relatively small sample sizes. They often didn't report doing power calculations to ensure they had enough patients to reliably detect a true difference if one existed. Follow-up times and methods were variable. All these factors contribute to some concerns about bias and the overall moderate certainty. They might have been underpowered, meaning the true effect could even be larger or perhaps smaller.
So we have a strong signal from studies that might not meet today's highest standards.
That's a fair summary. The OR of 3.02 is compelling, but it comes from evidence that has some methodological limitations, largely due to its age. It strongly suggests a benefit, but cries out for confirmation with modern high-quality trials.
Which brings us to another major gap you highlighted earlier, the integration with modern practice. What about superficial venous intervention, SVI? Did these studies account for whether patients had their underlying vein problem fixed?
This is another critical limitation, directly related to the age of the studies. The review found a significant lack of reporting on whether participants had received any SVI, like endovenous ablation or even traditional surgery.
So the studies mostly didn't say if the patients had the gold standard vein fix or not.
Correct. In most cases, the data simply wasn't there. And this is a huge issue for applying the findings today. We now know that treating the underlying superficial venous reflux with SVI significantly improves outcomes. Current guidelines recommend it strongly. So we're left wondering, does PTX provide this healing benefit primarily in patients who haven't had SVI? Is it acting as a sort of compensation for the unfixed vein problem?
Or could it still help even after someone has had ablation? An additive benefit.
That's the key unanswered question for contemporary practice. Does PTX still boost healing? Or, perhaps more importantly, prevent recurrence after the main source of venous hypertension has been dealt with surgically or endovenously? Future research absolutely must stratify patients based on their SVI status. We need trials that compare PTX versus placebo in patients who have had SVI, and compare PTX versus placebo in patients who haven't or can't have SVI. Only then will we know if PTX is a useful adjunct for everyone, or mainly a tool for those without access to definitive vein treatment.
Okay, so pulling all these threads together, the promising healing data, the moderate certainty, the huge gaps in recurrence and SVI interaction, what's the practical takeaway? If you're a clinician or a patient right now, what does this all mean?
I think the current status is this. PTX shows definite potential as a relatively low-risk, easy-to-use medication that can be added to standard compression therapy. The evidence suggests it significantly increases the chances of complete ulcer healing within about 6 months. So it's a readily available option that seems to offer a tangible benefit, particularly valuable, where access to specialist intervention is limited or delayed.
But there are real-world hurdles to using it effectively.
Absolutely. We have to be realistic. The big one is likely adherence. Remember that standard protocol, 400 milligrams 3 times a day, every day, for potentially 24 weeks.
That's a lot of pills for a long time.
It is. And we know from experience with many chronic medications, adherence to multi-dose daily regimens over months can be really challenging for patients. If people aren't taking it consistently as prescribed, then the impressive healing rates seen in the controlled trials might not fully translate into real-world outcomes.
Is there a way around that? Could the dosing be simpler?
That's something the review authors rightly highlighted as an area for future research. Could PTX be formulated differently? Maybe an extended release, once-a-day tablet. We've seen this happen successfully with other drugs used for venous disease, like MPFF, micronized purified flavonoid fraction, where simpler dosing regimens improved patient adherence without sacrificing effectiveness. Investigating a once-daily PTX option could be crucial for maximizing its practical benefit if the efficacy holds up.
Makes sense. Make it easier to take, people are more likely to take it. What about the economics? We started with that £2 billion figure.
Right, the cost implication. Logically, if PTX heals ulcers significantly faster and more often, it should be cost-effective. Faster healing means less need for expensive dressings, fewer nurse visits, potentially avoiding hospital stays or complications.
But is that proven? Did any of the studies actually look at the costs?
No, and that's another significant gap. Despite the clear potential for cost savings, none of the 10 studies included in this review performed a formal health economic analysis. So while we infer cost effectiveness, we don't have hard proof. Given the sheer scale of VLU expenditure, future large trials really need to build in a proper cost-effectiveness analysis alongside the clinical outcomes. Healthcare systems need that data to make informed decisions about recommending widespread use. Does the cost of the drug plus improved healing outweigh the current costs of prolonged management?
Okay, so better trials are needed. What's the main message, the call to action for researchers based on this review?
It's crystal clear. We urgently need new, large-scale, methodologically robust, randomized controlled trials. Trials designed to meet modern standards, proper randomization, blinding, handling of missing data, adequate sample size based on power calculations. These new trials need to, first, confirm the healing benefits seen in the older studies, hopefully increasing the evidence certainty from moderate to high. But the absolute highest priority for these new trials, recurrence. They must incorporate long-term follow-up, tracking patients for at least 1, preferably 2 or more, years after their ulcer has healed. We need that hard data on whether PTX helps prevent the ulcer from coming back and how long that protection lasts, if it exists at all.
And presumably, these new trials should also track SVI status.
Without question. They need to be designed from the outset to analyze results separately for patients who have and have not received superficial venous intervention. That interaction is key.
Is anything like this actually happening? Are these kinds of trials planned?
There is some encouraging news. The authors of the review did note that a protocol for a new, potentially large RCT called the eSPECT study has been registered recently. While the details weren't fully available at the time of the review's publication, the hope is that studies like eSPECT will be designed specifically to address these gaps: robust methodology, long-term follow-up for recurrence, and proper accounting for SVI status. The results of such trials will be critical.
So there's hope on the horizon for better data.
There is. The research community seems aware of the gaps and is hopefully moving to fill them.
Okay, let's try and synthesize this. Final thoughts. PTX for VLUs. Where do we stand?
I think we stand in a place of cautious optimism, but with major caveats. Pentoxifylline looks genuinely promising for accelerating and improving the rate of VLU healing. That odds ratio of 3 is a strong signal that shouldn't be ignored. It offers a potential benefit, especially alongside compression. However, its true value proposition, its ability to impact the chronic nature of the disease by preventing recurrence and thus significantly reducing long-term suffering and that massive economic burden, remains completely unproven based on current evidence. It's an unwritten chapter. We have a tool that seems to help fix the immediate problem, but we have no idea if it helps keep it fixed.
Which leads us perfectly into our final provocative thought for you, the listener. Consider this. We know that fixing the underlying vein problem with superficial venous intervention, like ablation, is crucial for long-term success. We now have moderate evidence PTX boosts healing. What if? What if those future high-quality trials finally show that PTX also significantly reduces recurrence, especially when used perhaps after successful vein ablation? Imagine using PTX not just to heal, but to protect the results of the intervention. Could that synergistic combination, fixing the main pipe, and then using a medication to improve the local environment and prevent relapse, become the new optimized global standard for VLU care? How fundamentally might that change outcomes and costs worldwide? That potential synergy, that's the really exciting frontier that needs urgent investigation.